Hello, my name is Dr. Philip Mease. I'm the Director of Rheumatology Research at Providence Swedish Medical Center in Seattle and conduct rheumatology practice in Seattle as well. Over the past 2 years, I've been the PI for a variety of CAR T cell therapy trials in combination with our hematology oncology division at my institution. And it's been quite a ride. So I've been taking on many of the cell therapy trials that have been conducted in autoimmune disease ever since the initial report from Erlangen, Germany, from Georg Schett's group showed how effective CAR T cell therapy can be in lupus. One of the sessions here at the ACR meeting was an overall review of CAR T cell therapy and a wonderful update from Joan Merrill. And she highlighted a meta-analysis that was authored by Nordman Gomez in Seminars in Arthritis Rheumatism. And what he did was review 16 studies, 13 targeting CD19 and 3 targeting CD19 and BCMA. There were 12 autologous CAR T trials and 4 allogeneic ones, and for a total of 145 subjects with lupus that were treated. So some summary from that included the fact that at baseline, these patients had very active disease with an average CDAI score of 13. And with treatment, this decreased to 2.3 after 6 months and 1.4 after 12 months. So it does show that it takes a little bit of time. You don't get immediate results, but ultimately very, very significant improvement in overall disease activity scores, with DORIS remission seen in 70% of patients, LDOS in 89% of patients, and drug-free remission in 84% of patients. So highly effective. And this mirrors our own experience working in clinical trials with lupus patients, where the longest out that we have is a one-year patient who is drug-free and having essentially no signs of lupus. Occasional rash, mouth sore, but really doing very well. Now, side effect wise, there are some very specific things that have been seen, including something called cytokine release syndrome, or CRS. And in this meta-analysis, that was seen in slightly over half of the patients, usually grade 1 or 2. And this would be, for example, fever or slight change in blood pressure, but overall very well tolerated. In our center, treated either with Tylenol or tocilizumab. In these reports, there were 4 cases of ICANS. ICANS is what is called immune effector cell-associated neurotoxicity syndrome, which can be confusion, for example, or word-finding problems, and usually quite responsive to either steroids and or other treatments, and we're rarely seen either grade 1, 2, or 3 most often. And then 7% of patients developed serious infections, and there was 1 case report of fatal pneumococcal meningitis. So there are potential side effects. In addition to the CRS and ICANS that I mentioned a moment ago, there can be cytopenias, hypogammaglobulinemia, and downwind reported in the cancer treatment literature, very, very rare risk of CAR-related cancers. A new toxicity that has been reported is an interesting one, known as LICATS, or local immune effector cell-associated toxicity syndrome. What is happening with this condition is that the patient may report a flare of some of their basic lupus symptoms, such as skin rash or arthritis or more proteinuria that occurs somewhere around 3 to 4 weeks after cell infusion. And this tends to be transient, pretty easily treated with steroids or tocilizumab. And it seems to be associated with an area where B cells have been ablated, and this may be a reaction to the B cells that are dead there in that particular tissue. Again, this is transient and tends to be relatively benign. We don't think that this represents a flare in their basic lupus activity. So what I liked about this overall presentation was how much it mirrored our own experience, both in terms of the degree of effectiveness that can be seen, including many patients with DORIS remission, but also some of the side effect profile. And there are a number of us who are conducting these trials that are now gaining the experience that the hematology oncology physicians have gained in their years of using this type of therapy. And so I think that clearly we're going to be moving into an era where this type of therapy can become available for other refractory lupus patients. It is expensive, pretty arduous, and there are going to be some possibly more practical, off-the-shelf allogeneic therapies coming along and T-cell engagers. We'll save that for another video to have a more in-depth discussion about those newer approaches. Thank you very much.